Nursing 209. Concept we're discussing today is perfusion. Exemplar is dysrhythmias. We're going to be talking about interpreting a cardiac rhythm strip. Required reading is listed here. Your medical surgical textbook, chapter 26, management of patients with dysrhythmias and conduction problems. Your fundamentals text, chapter 38, your pharm text, antiarrhythmic agents, pages 769 through 786. Your Maternity and Peds book really doesn't have much to do with this as far as dysrhythmias, but you can look over that. That's talking about the care of a child with alteration in perfusion and cardiovascular disorder. That will play with much more of our cardiac or our perfusion as we go along. Some additional resources that I think you will find very helpful. There's an article in Nursing 209, which I will post for you. It's volume 39, number 9, out of September 2009. I know that's it's 10 years old almost, but it's also very good. The www.skillstat.com is a demo type program where you can go in and actually see rhythm strips going across a monitor. You can pause them so you can see them a static type process. You can just click on a rhythm and it'll put it across the screen. You can also set up different types of quizzes where it'll put a rhythm strip across, and then you have the ability to take a look at that. The nursecom.com EKG primer is also very good, looking at rhythm strips. And then found one recently, one of your classmates showed me. It's Watch Learn Live at heart.org. It's put out by the American Heart Association. I'll think this one's actually very good. I think it's something that you will find very useful as part of the resources that you use to prepare for this. As we begin our study of dysrhythmias, you must go back and review the conduction system of the heart. Remember that when we're talking rhythm strips, all we're talking about is the electrical system of the heart. The electrical system of the heart. The electrical impulses begin in the sinoatrial node, which lays right in the right atrium, right where the superior vena cava comes into the right atrium. The SA node is the pacemaker of the heart, normally fires at about 60 to 100 beats per minute. Impulses travel from the SA node across the internodal pathways down through the atrium. It also travels down through the pathways down to the AV node. Your AV node lies just at the basically bottom of the atrium, just before you get into the right ventricle. This AV node is the secondary pacemaker of the heart. So if something happens to the AV node, then to the SA node, the AV node will take over. The AV node also works as a gatekeeper. Basically, it slows down the impulses coming from the SA node going into the ventricles. Without this slowdown, the atrium and the ventricles would contract at the same time. What you want to happen is that for the atrium to contract just prior to the ventricles contracting, what you get is what we call an atrial kick. So that delay in the AV node actually slows it down so that the atrium can contract, force more blood into the ventricles so that the ventricles have a greater volume in them, so basically the preload, so that then as the more volume, when the ventricles contract, you have a greater stroke volume as it goes out. Once it gets past the AV node, the impulse travels down to the aventricular or bundle of His. From the bundle of His down to bundle branches. From the bundle branches down into the Purkinje fibers, out into the muscles. So everything, normal pathways, begins at the top of the heart, works its way down toward the bottom of the heart. So as you begin to look at the pathways, your EKGs, when we look at a lead 2, we're looking across the heart this direction, and from that direction we're going to see a positive deflection, and we'll talk about that a little bit more as we go along. So we've talked about this. The SA node is located in the upper posterior portion of the right atrial wall of the heart. It is called the primary pacemaker of the heart. Firing rate is 60 to 100 beats per minute, and it represents the depolarization and myocardial contraction, depolarization of the atrium. And when that depolarization occurs, myocardial contraction occurs. So that basically occurs with the SA node, with the impulses leaving the SA node. The SA node discharges impulses at a rate of 60 to 100 times per minute. That was what we call a normal sinus rhythm. When we drop less than 60 beats per minute, typically we're looking at bradycardia, and if it's greater than 100 beats per minute, that is considered tachycardia. Continuing on, the A impulse travels from the SA node down through the internodal pathways, distributing all throughout the atrium. This transmission of the impulses from the SA node goes all the way down to the AV node, while it's also spreading out across the atrium. Bachmann's bundle is a group of interatrial fibers contained at the left atrium. Basically, it's a subdivision of the anterior internodal tract. It conducts the electrical activity from the SA node over to the left atrium. The AV node, or atrioventricular node, is located in the floor of the right atrium, just above the tricuspid valve. It's the only pathway of atrial electrical impulses to the ventricles. So every impulse that comes from the atrium has to go through the AV node to get down to the ventricles. Remember, this is also your backup pacemaker. If something happens to the SA node, the AV node takes up as the backup pacemaker. The AV junction is where the SA node joins the bundle of His. If the SA node fails or slows below the normal rate, the AV junctional tissues initiates electrical activity. So this is all of the AV node, the junctional, all that lies together. Again, works as a second maker. The bundle of His is the conduction pathway that leads out of the AV node. It lies at the top of the intraventricular septum. It's commonly referred to as the common bundle. It does have the ability to self-initiate electrical activities at an intrinsic rate of 40 to 60 beats per minute if necessary. The Purkinje network fibers spread throughout the ventricles. Basically, once it leaves the AV node, it goes down through the bundle branches, and from the bundle branches it gets down into the Purkinje network. These are the fibers that go into the ventricles and carries the impulses directly to the ventricular muscles. It's the Purkinje network that actually initiates the contractions and stimulation of the muscles to contract. Now, these Purkinje fibers also can fire on their own. If the SA node fails, the AV node fails, then they can actually fire at a rate of 20 to 40 beats per minute. Now, understand this rate of 20 to 40 beats per minute probably is not enough to maintain a good cardiac output, but it will keep the heart beating. So, how do we measure this electrical activity within the heart? We basically do it by placing electrodes to the skin. These electrodes are then attached to a machine that converts the electrical activity to mechanical documentation. You've all seen this. The electrodes basically contain a conductive gel that attaches to the skin and then is attached to a lead that goes back to the machine to give you the mechanical documentation. There are some things you need to know about applying electrodes to a patient. If you do not have good contact of the electrodes to the skin, you're not going to get a good reading. This comes from your med-surg book. Here's some of the things you got to do. You need to debride the skin surface of any dead cells. You need to wash the areas you're going to put those with soap and water and then dry very well. You want to use a washcloth or a gauze, something that's actually going to kind of debride that skin so that you'll actually get some contact. If there's a lot of hair, clip the hair from around the electrode sites. Do not shave it. Shaving leaves microabrasions which can lead to infections. connect the electrodes to the lead wires prior to placing them on the chest. The old, what we call the push-on buttons, if you put the electrodes on first and then tried to connect the electrodes to the leads to the electrodes, it was very uncomfortable for patients because you had to push very hard to get those on. So always attach the electrodes to the leads prior to putting them on the patient. Once you've done that, peel back the backing off the electrode. Check to make sure the center is moist with electrode gel. If they have been out of the package for a while, they will dry up. If there's no electrode gel, you do not get good electrical readings from the machines. So there are different places to put the leads, and we're going to talk about that, but always make sure you got the leads in the correct places. Your book says change the electrodes every 24 hours. I don't see that as common practice, but you do want to make sure you're checking the skin for irritations and trying to apply the electrodes to slightly different locations. Again, not something I see in general practice, but it should be done. Unfortunately, you do have patients that can be sensitive to the electrodes. There are special hypoallergenic electrodes. They're much more expensive, so do not use those unless you have to use those for a particular patient. Okay. So when we do electrical heart monitoring, there's two systems that we use. We use the 12-lead EKG. Now, in this section, we're not going to talk about the 12 lead. The 12 lead is used for diagnosing myocardial infarctions. It's also used for looking at angles of the hearts and for what we call different types of cardiomyopathy. You can tell many things from a 12 lead EKG. Reading a 12 lead EKG is not within the scope of practice of an RN. If you go to work in a CCU or an emergency room, you may become proficient in looking at the 12-lead EKG and knowing what's going on, but it's still not within the scope of the practice of a RN to read a 12-lead EKG. What we were responsible for are what we call telemetry or continuous rhythm strip monitoring. Now, this monitoring can take place by hard wire, where, like in the ICUs, the leads go from the patient to a hard wire to the machine, or like we see on most places in the hospital with telemetry, the leads are connected to a radio transmitter box that actually transmits that information to a monitor and to another room where it can be watched closely by monitor techs. Lead systems, there are several different types of lead systems out there. Most of the time you're going to run into 3 electrode lead, 4 electrode, and 5 electrode leads. Now, the term leads can be misleading because we talk about a 12 lead EKG. That means we're looking at the heart from 12 different directions, not that there are 12 leads connected to the patient. Just like when we connect these patients to these either using systems using either 3 electrodes, 4 electrodes, or 5 electrodes, we can look the heart at many different angles. So when we talk about lead systems, we're talking about the number of electrodes that are attached to the patient. Okay. So the 3-lead electrode system basically forms a triangle. You need to memorize these. Well, for the test, you need to memorize these. As you go out into work, most of the systems are going to tell you where to place the actual electrodes and the leads. So typically, white is on the right shoulder, black is on the left shoulder, and red is on the left midclavicular line at the lowest rib. The acronym to remember: white on right, smoke over fire. So your black's going to be kind of more over the red area as you look at it. With a 3-lead system, what we're typically going to do with all of our systems is we're going to actually look at this lead 2. Lead 2 goes across basically the angle of the heart. It follows the electrical pathway of the heart. It actually gives us the most proficient looking EKG. We get the best looking P waves and QRS complexes from a lead 2. So typically you're going to see most monitors set in a lead 2 setting. Again, lead 2 just means the angle we're looking at the heart. Lead systems are the number of contacts that are on the patient. Okay. The one you're probably going to see the most, the one you see at Huntsville Hospital most of the time, is basically the 5-lead system. And the 5-lead system basically has 5 electrodes that are attached to the body. And you can see here, as we look at it, white on right, green below it, black on left, red below it. So typically what you're going to see, you'll say clouds over grass, smoke over fire, ground in the center. So basically this is one. Now the systems can actually move this lead around to different spots. It can go here, or it could go down here. It can go to different spots, and depending on where this V1 lead is placed will give you a different look at the rhythm strip for the. There is a again, this is called the V5 system. You can see that we've moved the brown to a different location to give a V5 system. Again, what's going to happen is each hospital is going to have a way they do it, and the telemetry box is going to tell you where to put the leads and what location to put those leads. Okay, so why do we do this? Why do we monitor the electrical activity of the heart? Well, what we can see is patients who have disease process of the heart can have what's called dysrhythmias, irregular or abnormal beats. When we place a patient on an electrical monitor, we can continuously monitor their heart rhythm. We can see how many of those unusual beats they're having, what type of dysrhythmias they're having. We can set alarms for rates, and also we can store data and track trends. So it's very, very important as you look at these newer systems, they store the data and they actually will track trends. You can go back over time and see what kind of trends. Now the good part is most of these monitoring systems actually allow you to print out a rhythm strip on paper. That's really important because most of the time when we're looking at an electrical monitor, we're looking at somewhere between a 6 and 8 second strip. When we're looking at third degree heart blocks, second degree heart blocks, sometimes you need a longer strip to look at to really see the patterns that go along with that. So many times you're going to see basically a paper printed out to take a look at that strip. Before the EHRs came on board, most of the time these monitor strips had to be printed out and actually taped to a sheet of paper and placed in the chart as part of the records. Some of the EHRs are actually capturing the data and keeping that as part of the medical record for the. Now, one thing you need to understand, and with paper and with the monitors themselves, we typically, if you're using anything that runs a paper, or if you're looking at the EKG going across the screen, it's running at 25 millimeters per second. Now, when you get papers, the color is going to vary depending on the company. The size of the paper may also vary depending on the company. One of the things you're going to see is most of them are marked with 3-second interval markings at the top, and I'll show you as we look at them. Some of them are marked every second, but most of them are marked every 3 seconds. That becomes important when we start counting the heart rate on these patients. Understand that the horizontal axis represents time. The vertical axis represents electrical voltage. So as you look at a strip, understand there's a horizontal axis and a vertical axis. Now, again, we talked about the machines are actually set to run at 25 millimeters per second. You can change that speed, but most of the time we don't. You may see some of the cardiologists change the speeds to look at a rhythm strip to get a better look at the QRS complexes. This is our normal EKG paper. I'm going to show you just a 3-second strip, but typically when we look at EKG papers, we're going to be looking at 6-second strips. As we look at the EKG papers, we're going to look at two things. As it runs along the horizontal axis, this is time. As you run across the longitudinal axis, this represents electrical activity or amplitude. Okay, so as we look at our paper, it's broken down into boxes. These boxes are important as we begin to look at our rhythm strips. A large box, such as this one, is represented here. Went to the wrong box, but that's okay. You can see what I'm talking about. These boxes basically are 5 millimeters in length and represents 0.2 seconds. 0.2 seconds. So 5 millimeters in length and 0.2 seconds. It also represents 5 millivolts of electrical activity. Now these are further broken down into smaller boxes. You can see the smaller box here. The smaller box represents 0.04 seconds. So there are 5 small boxes and 1 larger box. So you can see you multiply 0.04 times 5, you get 0.20 seconds. It becomes very important as we start looking at heart rate and we look at our PR intervals, our QT intervals, our QRS intervals to know what the size of these blocks are. So you need to memorize that one small block is 0.04 seconds. One large block is 0.2 seconds. 0.2 seconds. Again, we will talk a little bit about amplitude. That really gets in as we're monitoring 12 EKGs more than it does monitoring rhythm strips. But it does become important as we look at those processes. So here's what I was talking about when we talk about the different ones. You can see here to here to here. This represents 3 seconds. And this represents another 3 seconds. Now if you look, there are 1 second marks here and here, here, and here. Let me erase that. That didn't turn out too good there. But you can see the marks. But see our marks here. From here to here is 6 seconds. What you're going to do, and as you're testing, as you're taking my test and most tests, you're going to be looking at a 6-second strip. Very important to make sure you have 6 seconds. So look for the markings. Some are at the bottom, some are at the top. Depends on which paper and which company you're getting from. But you need to look for these 3-second or 1-second marks. You always want to take and look at a 6-second block. Okay. Again, just another representation of monitoring paper. You can see that basically the one small block is 0.4. If you get 1.5 blocks, it's 0.06, 2 blocks 0.08, and goes right on down, where 5 blocks is 0.20 seconds. This becomes important as we're looking at our PR intervals, looking at our QRS intervals. All this becomes very important. Amplitude becomes important as we look at ST segments and we look at Q waves. The amplitude becomes important as we look at those. So this is the normal electrical cycle of the heart, where we have a P wave, which represents basically the firing the SA node and the depolarization of the atrium. The PR segment represents that delay that we talked about at the AV node. What we measure most of the time on our rhythm strips is this PR interval. Well, there we go. From there to there. That's a PR interval. That basically is how much time it takes for the electrical impulse to get from when it's fired at the SA node all the way down to the ventricles to initiate the electrical activities in the ventricle. That is the PR interval. The next thing we look at basically is the QRS complex. Now we'll talk about this a little bit more, but a QRS complex represents ventricular depolarization. Ventricular depolarization, and it goes, first downward slope is the Q wave, first upward slope is the R wave, the first second downward slope is the S wave, and then it should come back up to the ST segment here. The ST segment is from the end of the QRS complex to the beginning of the T wave. We look at this ST segment. We don't measure the ST segment. We measure what's called the QT interval, which is from the beginning of the QRS complex to the end of the T wave. As that gets longer, it causes more problems for the patient. Then we have the T wave. The T wave represents ventricular repolarization. And then we have a U wave, which is not seen on all EKGs, but you need to be aware of that. So this is the electrical cycle of the heart. And you can see our normals, basically our PR, QRS, and QT intervals. We'll talk about normals as far as that goes. I know this doesn't show up very well, but when you get your printouts, this will give you a lot of information and talk about some of the different things we just. Now let's begin to explore that entire complex, that entire electrical complex from beginning to end. We're going to begin with the P wave. The P wave is the first wave produced, and that's produced from the electrical impulse from the SA node. When we look at the P wave in lead 2, and most of our strips are going to be in lead 2, the P wave should be smooth, rounded, and have an upward deflection. You can see here that basically that the P wave is upright and kind of rounded. So that's what we want to see in a P wave. Now remember, this P wave represents depolarization of the left and right atrium. Also remember that these electrical impulses that we're seeing do not represent mechanical activity of the heart. You actually can have electrical activity in the heart without having mechanical activity in the heart. So understand, this is just looking at the electrical system of the heart, not the mechanical system of the heart. Now the PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. It represents atrial and AV node depolarization. This is the time it takes the electrical impulse to get from the SA node down to the AV node and down through that AV node to actually start the initiation of the ventricle electrical system. It basically, normal duration is between 0.12 and 0.2 seconds. So think about it. 0.12, that's 4 small blocks to 5 small blocks. Excuse me, I said that wrong. Let me say that again, okay? 0.12 is 3 small blocks to 5 small blocks, or 1 large block. So anything longer than that is abnormal. Anything shorter than that is abnormal. So you've got to look, that's where those small blocks, and knowing the time interval on those small blocks is very, very important. Now let's look at the QRS complex. The QRS complex represents ventricular depolarization. Represents ventricular depolarization. As we look at the QRS complex, it basically has three waveforms. Now understand, and we'll get into it a little bit more, that the QRS complex is what we're going to call it everything as a generic term. But there may be waveforms, QRS complexes with no Q wave, with no S wave. And we'll show you some of those as we go along. But understand that the first downward deflection of this complex, the first downward deflection, which is this deflection here, that is your Q wave. Your first upward deflection is here, going from here to here. That is your R wave. Then your downward deflection is your S wave. And then it will come back up to what's called the isoelectric line, and then you'll have a T wave. Okay, so the QRS complex, basically, Q wave is your first downward deflection. The R wave is the first upward deflection. It's usually the largest deflection seed in lead 1, 2. The S wave is the downward deflection after the R wave. Normally, a QRS complex is somewhere between 0.06 seconds and 0.10 seconds. Pretty much most books say that if the QRS complex is less than 0.1 seconds, 3 small blocks, then you can consider it as normal. Anything greater than 0.12 seconds, greater than 3 small blocks, is considered a wide QRS complex. There's some type of conduction delay somewhere within the electrical system of the ventricles that's making that QRS complex wide. So think about that anything greater than 0.12 seconds is abnormal. And I think we talked about this, that basically their QRS complex represents conduction of the impulses through the ventricular muscle. It's really looking at ventricular depolarization, and that mechanically what it's doing is initiating systole. Now remember though, we talked about you can have electrical activity without having mechanical activity. These are the different QRS complexes that are that you can see. Take a look at this. I'm not going to quiz you on this, but just kind of understand it. We will call those, if you looked at it generically, you're going to call all those QRS complexes, but they're really like, depends on how you what book you read. I just want you to know they're QRS complexes. That's what I want you to know at this point in time. Okay. Again, just another type of QRS complexes. As you learn more, as you dig deeper into this, especially those of you who love cardiac, these will mean different things to you. When you see the R prime, or what we call the bunny ears, or when you see a deep Q wave, those have significant meanings as far as cardiac rhythms. Not for you and the beginner. Okay. So the next wave we're going to see is what's called the T wave. It always follows the QRS segment, and it represents ventricular repolarization. Ventricular repolarization. It should be slightly rounded and have a positive deflection. This is actually the resting cycle of the heart. The resting cycle of the heart. Again, it represents repolarization. Now, that's the next thing that we'll look at. We look at the, and again, it's produced by repolarization, commonly seen as the first upward or positive deflection following the QRS complex. The T wave can be upright or it can be inverted, and those have different meanings as we look at. Okay, T waves can be shaped differently, and differently shaped T waves have different types of meanings. So you can see tall peaked, or what we call tinted T waves, or you can see inverted T waves. The tall peaked or tinted T waves usually indicate either myocardial injury or in most cases hyperkalemia. You can see the T wave here, 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 and here as you see changes, okay? A basically is a normal potassium. B is a potassium of about 7 milliequivalents. C is a potassium of about 8 to 9. And D is a potassium of greater than 10, which is really not compatible with life, okay? So those are some things you see. So if you see a tall peaked T wave, the first thing you really should consider is hyperkalemia. Now, if you see an inverted T wave, especially in leads 1, lead 2, leads V through 6, that may represent some myocardial ischemia. Then you begin to wonder, why are we not getting enough oxygen to that heart muscle? And that's a cause for concern. So if you're monitoring a rhythm strip and your T waves have been upright and then you actually see them then start to be inverted, that is a cause of concern. It tells me that there's not enough blood flow, that either what's happening is the oxygen demand has outgone the oxygen supply, or we're decreasing the oxygen supply to the heart muscle. So that we need to take a look at. We need to look at our patient and see what's going on. Okay, the ST segment is the next thing that we look at. That's basically the space between the end of the QRS and the beginning of the T wave. It should fall on what's called the isoelectric line. The isoelectric line is the area, is basically the baseline for all of your QRS complex. You can see our isoelectric line at the top of the yellow line here. That's our isoelectric line. So the ST segment should be along that isoelectric line. If we see problems with that T wave, whether it is elevated or whether it's depressed, that can indicate myocardial ischemia, or the injury has occurred at that point in time. So when we look at that ST segment, what we're looking for is it is it going up above the isoelectric line, or is it going down below the isoelectric line? But it should come back to that isoelectric line. Okay, so you can see here's our isoelectric line, and look where our T wave is, or ST segment. It's up here. Again, look where our isoelectric line is, and look where our ST segment is located. Again, here's our isoelectric line, and see that our T wave is down. ST segment is down, and it's dipped. This inverted and dipped usually indicates a digoxin toxicity. This ST depression, ischemia, this ST elevation, infarction. So if you see this ST elevation, that's a point of concern. You need to be working very quickly with that patient. There means there's heart muscle dying at that point in time. So this is an emergency type situation. And you can see here are some different ones. If I saw this, I hooked a patient up to a monitor, and I saw this, I would be getting a physician immediately. This patient is having an MI and needs to be treated appropriately. But you can see there's some ST depressions, different types, and you'll hear them talk about upsloping or horizontal or downsloping. Don't worry about that. Just look at that ST segment. The main thing I want you to understand, if you see ST elevations such as this, that is myocardial injury. That's an infarction taking place. These can be caused by ischemia or can be caused by medications. These are less of a problem. But if a patient has been running normal and then flips on one of these, then you need to let your healthcare provider know what's going on with your patient, that there has been a change in the rhythm. Okay. The QT interval, you don't hear that discussed too much, but that occurs from the beginning of the QRS to the end of the T wave. It represents ventricular ventricular depolarization and repolarization. The QT interval can vary. It can vary with the cardiac cycle. It can vary from whether it's regular or not. It can vary with gender, with age. So there is something called the corrected QT. You'll see it written as QT in capitals and a small c to kind of look at those. There are certain medications that we must look at that are going to increase this QT interval. So if we bring these patients in and start them on this medication, part of the measurements that the nurse will take is to actually measure this QT interval. The longer this QT interval, the greater risk there is that basically a patient can have a firing of an electrical stimulus here on the downward slope of the T wave and cause this patient to go into either ventricular tachycardia or ventricular fibrillation. So a longer QT interval is something that we'll look at with particular methods. The U wave is kind of the last wave. It may not always be seen on EKG strips. It's kind of rare to see it. We're really not sure specifically what the cause of origin. It's not really understood. It appears smaller than T wave. It's usually rounded and upright and a positive deflection if they are present. My hypothesis is that a prominent U wave, as you see here, is either related to hypokalemia, hypercalcemia, or either digitoxicity. If you see a U wave, don't look at it, document it, and continue to watch it. Look at your electrolytes, look at if your patient's on digoxin, and kind of monitor from there. Again, if it's something that is new, then let your provider know about that process, that you have had a change in the EKG, you now have a U wave showing up. So let's review. Let's just review our EKG waveforms. The P wave represents atrial depolarization. The P wave is here. We measure the PR interval, which is the amount of time that it takes for the firing from the SA node to get all the way through the AV node to actually stimulate the ventricles. Then we look at the QRS complex. Okay, we look to see how wide it is. Do we have each of our points? Do we have a Q wave, an R wave, an S wave, or do we just have a Q wave, a prime? Look at that. When we look at the QRS complex, we're looking to measure what our length of our QRS complex is, and looking to see if it's less than 0.12 seconds. With our PR interval, remember, it should be between 0.12 seconds and 0.20 seconds. So basically 3 to 5 blocks. We look at our ST segment. We're looking to see if it's elevated or it's depressed. We're looking at our T wave. We're looking to see if there's any peak in our T wave or if our T wave's inverted. And then we look at our U wave. Is there a U wave present as part of that process? Okay. Let's take a short break here. We're going to begin to look at interpreting a cardiac rhythm strip. I think this is pretty appropriate for you nursing students and me right now as I'm fighting to stay awake as I provide this lecture. Let's look at some general rules for actually interpreting a rhythm strip. The one thing I want you to understand, the rhythm strip is a tool for assessing your patient. So the first and most important thing you must do is always look at your patient, assess your patient. Match that strip to what your patient looks like. Don't just treat the rhythm strip, treat your patient. As you begin to look at rhythm strips, Read every rhythm strip from left to right, starting at the very beginning of the strip. If you try to start in the middle, you're going to miss something. So start at the very beginning of the strip and move to the right. Go from the left to the right. And apply a systematic approach to each strip. You may find your own way. I'm going to teach you two ways. I'm going to teach you a 5-step, which I use, and I'm going to show you the way the book talks about doing it. So as you begin to look at rhythm strips, it's always good to set up a system. Do it the same way each and every time till it becomes secondary. Basically, it becomes just part of you to do it that way. So I really want you to learn a systematic approach to looking at rhythm strips. This is the 5-second approach that I like to use. Uh, this is what I normally teach. I like it, and I think it works. It works well for me. So as you look at a rhythm strip, you're going to look at these 5 different things. The first thing you're going to do is look at the heart rate. And we'll talk about how to calculate the heart rate. But you want to look at the ventricular rate, which are the QRS complexes. You want to look at the atrial rate, which are the P waves. So you're going to look at the rate of the atrium and the rate of the ventricles. Then you're going to look at the rhythm. Is it a rhythm? Are the QRSs, are they in rhythm? Are the P waves, are they in rhythm? So we'll talk about doing those, but you're going to look at that rhythm. What you're going to look at is the distance between each of the QRS complexes. Is it consistent? The distance between each of the P waves, are they consistent or are they irregular? When we talk about rhythm, we're going to talk about regular, occasionally irregular, or regularly irregular, or irregularly irregular. So when you do those type things, as you look at your rhythm strip, you'll understand. We're going to look at the P wave. Most of the times the P waves, because we're using a lead 2 strip, are going to be rounded and upright. And that's what you want to see. As you look at that P wave, is there a P wave for each QRS complex? Does a P wave precede each QRS complex? Then you're going to look at the PR interval. What's the distance of the PR interval? The PR interval should be between 0.12 and 0.20 seconds. If it's longer than 0.20 seconds, then we have a problem. We need to look into what might be causing that problem. Then we're going to look at the QRS complex. What's the width of the QRS complex? Is it wide? Is it greater than 0.12 seconds? Is it wide and bizarre as in a PVC? How does it look? Is it regular throughout the full strip? Then we're going to look, is there a QRS following each P wave? When you do these 5 steps, it's going to help you, it will lead you to the analysis of the rhythm strip. Your textbook also has a systematic approach to looking at cardiac rhythm strips. It's very similar to what I just told you. They just go in a little bit more detail in writing. So the first thing they recommend is when you look at that rhythm strip, just like we talked about, read it from left to right. What you're going to do first is determine the ventricular rate. That's counting the number of QRS complexes. Then look at the rhythm. Is the ventricular, when we look at the QRS complexes, is it regular? Then look at the QRS duration. Is it between, or is it less than 0.12 seconds? If it's greater than 0.12 seconds, 3 blocks, then we need to look deeper into what may be causing the problem. And then basically, is that QRS duration consistent throughout the strip? Do all the QRS complexes look the same? Are there some that are very unusual in shape, wide, bizarre? If there's anything that's unusual, then we need to look into what might be those abnormal QRS complexes. Then you want to identify your P waves. Is there a P wave in front of each QRS complex? What's the shape of that P wave? Is it up, rounded? Is it inverted? Where is that P wave? Is it in front of the QRS? Is it behind the QRS? Is it consistent throughout the rhythm strip? Is the shape and the PR interval consistent throughout the rhythm strip. Then they want you to determine the atrial rate. That's basically counting the number of P waves in a 6-second strip, multiplying it by 10. Then, are the atrium beating at a regular rhythm? Then you need to look at that. Then look at the PR interval. The PR interval should be between 0.12 seconds, which is 3 small blocks, and 0.2 seconds, which is 5 blocks. With the PR interval, are they consistent throughout the rhythm strip? In other words, are they the same length? Is there a pattern? If they're irregular, is there a pattern to their irregularity, or just nothing to it? There should be a correlation between the P waves and the QRSs. There should always be in a normal strip, one P wave for each QRS complex. If there's more than one P wave for each QRS complex, or more QRSs than there are P waves, we have an abnormality. So if you do these will help you identify specific problems in the rhythm strip. Determining the heart rate is very simple. I'm going to teach you the simple method. I want you to learn the simple method and use that as you go through this program. Basically, when we're looking at the heart rate, we're going to count the number of electrical impulses as represented by either the P wave or the QRS complexes conducted through the myocardium in 60 seconds. To determine the atrial rate, we're going to count the number of P waves. To determine the ventricular rate, we're going to count the number of QRS complexes. The system I want you to do, well, let's go back to this. Just a refresher. Remember, the SA node is the driving pacemaker of the heart. It fires at 60 to 100 times per minute. If a rhythm is less than 60 per minute, it's considered bradycardia. If it's greater than 100 beats per minute, it's tachycardia. The method I want you to use for determining heart rate is called the 6-second method. Basically, you're going to count the number of QRS complexes in a 6-second strip and then multiply that by 10. That's going to give you your ventricular rate. You're going to count the number of P waves in a 6-second strip, multiply that by 10. That's going to give you your atrial rate. Let's look at an example here. Here is a 6-second rhythm strip, and we determined 6 seconds by the markers at the bottom of the strip. Now, they can be at the top, but this one's at the bottom. This is a marker here. So the distance from this marker to this marker, whoops, went too far. So the distance from this marker to this marker, that's 1 second. Then this is 2, 3, 4, 5, 6 seconds. Again, you see the dark ones. The distance between the dark ones is 3 seconds. You can see here, from this dark to this dark line is 3 seconds. So this is a 6-second strip. So to determine the rate on this strip, we're actually going to count the number of QRS complexes. So it starts here. So here's 1, 2. Well, it's not working. There we go. 2, 3, 4, 5, 6, 7, 8. So we have 8 QRS complexes in a 6-second strip. So basically 8 complexes in a 6-second strip gives us a rate of 80. Now we're going to do the same thing for the atrial rate. So we've got 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 P waves. So our atrial rate is 60. Does that make sense to you? Straightforward. If you've got a 6-second strip, You're going to count the number of complexes in that 6-second strip, multiply by 10, and that will give you a rate. It's going to give an approximate rate, and that's all we really need is an approximate rate on these strips. We don't have to have an exact rate. The only way to get an exact rate is go into that patient's room, put your stethoscope over their heart, and count the number of sounds for 1 minute. That's going to give you the most accurate rate for that patient. But that's not what we're going to do. We're looking at rhythm strips. So 1, 2, 3, 4, 5, 6, 7, 8 QRS complexes. Our ventricular rate is 80. And I put 60 down here. I didn't go very well on that. Tried to write with this. I apologize. And our atrial rate is 1, 2, 3, 4, 5, 6, 7, 8. So our atrial rate is also 80. So 80. My mouse doesn't write very well. I apologize. Okay. There's another way to determine the rate. You can use this one if you have less than a 6-second strip. You're basically going to count the number of large boxes between 2 R waves. Now, it works very well if the heart rate is regular. Doesn't work if the heart rate is irregular. So to do the R to R interval, we're going to count the number of large boxes between 2 R waves and then divide that number into 300. So if we look here, we're going to count from this R wave to this R wave. And they don't really fall, so we've got about a half a box. So there's 1, 2. If you look, there's about 3 small boxes there. 1, 2. There's about 3 large boxes. So we divide 300. Divided by 3 equals 100. Now, what if we use our 6-second strip, counting the number of complexes? So let's look. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times 10, 100. So you get the same rate on using both methods. If we counted the P waves, we'd have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we have an atrial rate of 100 as well. And we could do the same thing counting the number of complexes from this one to this one, dividing that number into 300. You would see there's about 3 large boxes. Let's try to see if there's one that fell right on it. This is close. You can see this one's right before the beginning of that one. That one's right before the beginning of that one. So there's 3 boxes in there, so that gives us a rate of 100. If you have less than a 6-second strip and a regular rhythm, that's an easy way to do it. There's another accurate way of doing it, and I'll show you after this one. This one requires some memorization. When you look at this particular here, this one, basically this requires memorization. You have to have a QRS complex that falls right on one of the dark lines. You can see the dark lines here. You need to find a QRS complex that falls on the dark line, and you're going to count down till the next QRS complex, and it falls here. Then you're going to have to remember the first line is 300, the second line is 100, the third line 300, 150, 100, 75, 60. Then it goes to 50, and it goes on down. So I'm at 75 here, and I'm at 100 here. So I've got 5 blocks, and I've got 75 to 100. That's 25. 25 divided by 5. So each one of these small blocks would be 5 beats per minute. So I'm just a little beyond 75. So if I count it, I got about 2 blocks. I'm going to have a rate of about 80. Again, this is for more advanced folks, but I did want you to see it and take a look at it. We talked about another way. If you only have, you can use the number, just like we did the R to R. Here's the R to R. We would count the number of small blocks between the R to R interval. Here's the small blocks. 1, 2, 3, 4, 5. Here's another 5. There's 5, 10, 15, 20. There's about 22 blocks between the two. So if I divided 22 into 1500, that's going to give me a rate of 68 beats per minute. Again, these work very well if you have a strip that's less than 6 seconds. Okay. We've determined our rate. We've determined both our ventricular rate and we've determined our atrial rate. So the next thing we want to do is actually look at the heart rhythm. Rhythm describes the beating of the heart in a sequential manner. So in other words, it's going at a very regular pace. When we classify rhythms, they're classified as either regular or irregular. When we talk about regular, the interval between the R waves is consistent throughout the strip. There'll be the same number of little boxes from one QRS to the next QRS to the next QRS to the next QRS. Irregular means there's a difference. You might have 30 blocks between this QRS and this QRS, then you may have 75 between this next two. It's an irregular pattern. You can have a regularly irregular pattern, you can have an irregularly irregular pattern, or you can have a consistent irregular pattern. So as we look at rhythms, we're looking at the rhythm of that QRSs and the P waves. This is one of those things you can't really eyeball. There's 2 or 3 ways to do it. You can use calipers. Unfortunately, you won't have access to calipers on the test. So you're going to have to use the paper pencil method or the counting method. Now the paper pencil method you should be able to use on the test. You're going to need your sheet of paper that you're going to get for doing your calculations on, and you're going to be able to lay it on the screen. You're going to take your piece of paper, lay it up on the screen here, and then on that piece of paper you're going to mark this QRS complex and this QRS complex. And then what you're going to do is you're going to slide that paper down and match this up. So when you slide it down, this one goes here and this one comes here. So what you're doing is you're seeing is the distance between this one and this one the same as the distance from here to here and here to here. Now there can be a slight variation. You can have a variation of 0.6 seconds, which is 1.5 small blocks, and the rhythm still be considered regular. So you can do that. The other way you can do it is you can sit here and count the number of little bitty boxes between each QRS complex and determine whether it's regular. That's a little tedious, but it works. So you can do that as well. Again, we talked about irregular rhythms. They can be regularly irregular. In other words, the irregular rhythm occurs in a pattern. They can be occasionally irregular. Intervals of only 1 or 2 R to R's are uneven. That can be with PACs, with PVCs. Or there can be an irregularly irregular rhythm. There is really no similarity between the R to R intervals. The irregular rhythm, you hear that, you need to think atrial fibrillation. So let's practice this strip. Let's take a look. Let's start from the beginning. What do we do first? That's correct. We want to check our ventricular rate. So here's our box. Here's our 3 second, 3 seconds, 3 seconds. So we have a 6-second strip. So we count 1, 2, 3, 4, 5, 6. So we have a ventricular rate. So our V rate equals 60. I'm sorry, I don't know why that changed to yellow. All right. Then we're going to basically look at our atrial rate. So here's 1, 2, 3, 4, 5, 6. So we have 6 P waves. So we have a atrial rate is 60. So if we look at this strip, there's a P wave for each QRS. There's a QRS for each P wave. Then we're going to look, what does our P wave look like? Our P wave is upright and rounded. It's upright and rounded on each one of them. We're going to look at our PR interval. So the PR interval, whoops, I don't want that, I want that. So we look at the PR interval. It's coming from here to the beginning of the P wave. So we can see that's about 4 boxes. 4 small boxes is 0.16 seconds. And if we look, it's consistent throughout. Then we would look at our QRS complexes. What's the width of our QRS complex? It looks like it's about 2 boxes, maybe a little bit more. So that's about 0.08 seconds, maybe 0.1 seconds, but it's less than 1.2 seconds. So that is normal. So as we look at this, we would call this a normal sinus rhythm. We would take our paper and lay it here and here and move it from here to here, from here to here, or we would sit here and count the number of little boxes in each one. So this is a normal sinus rhythm. Okay. Now, our Q waves can be different shapes, so don't you get bent out of shape because the Q waves are different shapes. Just call these QRS complexes. There are different determinations that we use when we're looking at cardiology type terminology. This is a QRS, this is an RS, this is a QS, this is an RS, this is an RS prime, then a QR and a QR. So don't worry about it. The main thing is look at it. Is it consistent throughout the strip? What's the width of it? Is there a Q wave for each PR, each P? Is there a P for each QRS complex? That's what I really want you to know. You can see here the QRS complex here. It's the QRS basically represents depolarization of the ventricles, not the contraction. You can have electrical activity without having mechanical activity. Now, hopefully, when we get that depolarization of the ventricles, we will get the depolarization of, or get the contraction of that. So when we look at the QRS complex, the first downward deflection is the Q wave. First upward deflection is the R wave, and the sharp negative deflection that follows the R wave is the S wave. Okay. So we talked about this already. When you're doing the analyzing, basically determine the QRS duration and throughout the strip. This is just a review for you. Okay. So again, just another way to look at the QRS complex. This is the system. So where QRS, here's a Q wave, the R wave, and the S wave. And then that comes back up. Here's our ST segment. Okay. And again, this is just all about analyzing the strip. So here are some sample QRS complexes. Again, you've got a downward slope. You've got a ST segment going down on this one. Here you got a R, S, R prime. You've got the QRS, an RS, an RR prime. So there's different types of shapes. Get bent out of shape over that. Now, we talked about looking at the QRS complexes and looking, is there consistency? You look at this QRS complex, it looks totally different from the other ones. Notice that it actually is early. If you were marching this out, took your paper and went here and went here, you would see that one goes there, that one, and then you would see that basically one should actually fall here, and then it's going to be irregular to this one. That's called a compensatory pause. So don't worry about a lot of that. We see here we've got the same wide looking bizarre, and we'll talk about these. These are PVCs, and these are just another type of QRS complex. The P wave, we've talked about it. Identifying that P wave, identifying the shape, determine the atrial rate, the rhythm, and how many P waves for each QRS complex do you have. 5 questions asked about the P wave we've talked about. Are the P waves present? Are they occurring regularly? Is there one P wave for each QRS complex, or is there a QRS for each P wave present? Are the P waves upright and smooth and rounded, or are they inverted? And do they all look similar? PR interval, again, measure from the beginning of the P wave to the beginning of the beginning of the P wave, yes, to the beginning of the QRS complex. That PR interval should be between 0.12 seconds and 0.2 seconds. So 3 to 5 small boxes. If it's longer small boxes, then you have what's called a first degree AV block. Are those PR intervals consistent across the? Again, looking at those intervals. Now, these are some practice. You can practice on these. Look at this one though. Do you see any P waves? I don't see any P waves. This is where it should be, but there are no P waves here. So this has an absence of P waves. So this is an abnormal rhythm strip. So you would need to look at that and see what's going on. Why is it abnormal? Okay. So again, some practice strips. You can practice those. Now, other things to look for, the U wave, the ST segment, and the QT. We'll talk about those. Now, we talked about in the very beginning that when you set these systems up, you've got to make sure that your contact pads are in good contact with the skin. You've got to clip the skin, rough the skin up a little bit. If you don't get good contact, you can get what's called artifact. That can come from patient movement, loose or defective electrodes. Today we don't see 60 cycle interference because everything is well grounded, but you can see that. And you can also have problems with faulty. If you don't have good contact to the skin, good enough gel, it's loose from the skin is wet or moist, you can develop what's called artifact. And you can see here that basically we see a P wave and a P wave and a T wave, but it really looks funny. The baseline looks kind of funny. It's just kind of wavy, and that's just artifact. With that, I'd want to go check my patient, see what's going on, make sure every lead's in place. So that's just one of the things that you would need to look for. If you have any questions, please let me know. We will work on that for you. Have a great day.